Good evening to everyone present today. Well, more of the aspirants will be joining us soon. So, the topic for today is obstetric emergencies, and the speaker that we have here is Dr. Neeraj Kumar, who is Associate Professor, Anesthesiology and Critical Care AIMS, Patna. Thank you, sir, for being with us. You can start your class. Thank you.
Thank you, Fatima, for kind introduction, and I will be welcoming all our EDIC participants. Just I will request all those participants to keep your mic in mute mode, and thus today's class will be really a very interesting and important one. Why? Because this is one of the very infrequent topic that is going to be asked in many of the EDIC 1 exam. And Meanwhile, what I have done that I have tried to cover many of the topics related to obstetric emergencies, following which that I will be discussing what will be the physiological changes of the pregnancy, and then few important obstetric emergencies like acute embolism, amniotic fluid embolism, then your peripartum hemorrhage, preeclampsia, eclampsia, severe eclampsia. And meanwhile, what I've done that I have given few of the questions, that is type A as well as type K questions. So I will request all those candidates who are attending today's class, they can write the answers on the chat box only. Either the answers would be in the form of TT, like true statement, false statement, like that, or any of the options that you feel is correct. If the option is only one option is correct, like if the type A is there, so you can answer based on that only. And meanwhile, I will also request again that don't try to unmute your mic in between, because it entirely disturbs the class, and it breaks the uh, momentum as well. So I will not wasting much time. I'll just share my screen. Just wait. So the first important thing is that why these obstetric emergencies? Why? Because we know that these pregnant patients and the patients who are postpartum women, they always requires ICU admissions if they have pregnancies that is complicated, right? And it constitutes only 1% of the patients. If you'll see this data, only 1% of the pregnancies, and even less than 1% of these patients needs a ICU admission. So you can think that it is very rare, but it is very, very important, and it is very, very crucial. It is very, very critical to manage those patients. And they are primarily admitted not for the gynecological conditions, but they are primarily admitted for obstetric conditions. And most of these women are mostly, they develop some complications postpartum, with few exceptions like trauma and cardiomyopathy. They may occur in the prepartum period as well. Okay. Now, coming to the one study, they have suggested that sequential organ failure assessment score, like SOFA score, is one of the better, is not a better, it's one of the better system for predicting mortality in obstetric patients. So if we'll get a simple question that which one of the following scoring system is useful in predicting the mortality of obstetric patients, and if the SOFA is one of the options is there, so you may tick SOFA as one of the correct answer. And then these actual mortality rates are dependent on the disorder that can cause that ICU admissions. So let's see. So how? So they have done one study that was published in Hong Kong Medicine Journal in 2010, where they found that 50 obstetric patients were admitted to the ICU in Nether Seoul Eastern Hospital, and they collected this data from January 1998 to December 2007. What they found that out of these 50 obstetric patients, 0.65% of the total ICU admissions were, means out of 7692, 50 patients were having obstetric patients that required ICU admissions. And you see, out of these, 0.13% of all deliveries. So most of the patients, those who have admitted, they underwent that deliveries. Now, coming to the causes, if you'll see that cause, what will be the most common obstetric causes for that ICU admission in that 50 number of patients? So you'll see that first, the postpartum hemorrhage is topping the list. So this PPH is still one of the most common forms of admissions for the ICU. And then after that, pregnancy-induced hypertension, in which eclampsia, severe preeclampsia, as well as HELLP syndrome, which also uh, encountered in those complications, whereas amniotic fluid embolism, ruptured ectopic pregnancy, peripartum cardiomyopathy, and few less than 1% of these, one or two cases were from retained placenta or from septic abortion. So still, PPH is one of the most common cause or frequent cause of ICU admission. A few of the non-obstetric causes were also there, out of which the sepsis was following UTI infections, and then some respiratory tract infections as well. Few of the patients were admitted because of the chronic rheumatic disease as well, and few of the viral infections in the form of encephalitis or meningitis. Now, coming to the pregnancy adaptation, again, this is very important and futile topic for the questions that is going to get asked in frequently. They used to ask from pregnancy adaptations as well. Why? Because many physiological changes occurs during the pregnancy to adapt to the requirement of the fetus and placenta. That we all know. To maintain that equilibrium, the fetus between fetus and placenta, these physiological or these adaptations usually happens, and these happens in almost all organ, not a single organ system that is going to be not going to get adapted following this pregnancy. While the important roles in changes in the hemodynamic monitoring and ventilation, that's why these two things are very important for hemodynamic monitoring, as well as for ventilating these groups of patients. And now you see that why it is there, because of the progesterone, because this progesterone is responsible for most of these adaptations, and because it is one of the potent smooth muscle relaxant as well as respiratory stimulant. That's why hemodynamic monitoring, because of the smooth muscle relaxant effect, as well as respiratory stimulant, so it impairs the ventilation as well. And what happens most of the time after delivery, about 6 weeks it takes for the maternal physiology to returns to the normal. So again, it may be asked that what is the normal physiological adaptation at which the maternal physiology returns to the normal. So it may be one of the fact-based questions that may be asked in your exam. Now coming to the next part, that out of which adaptation most frequent, yeah, most dramatic is the cardiovascular system. So cardiovascular system is again most important physiological changes, which is important for all of us. Now what happens exactly in these patients, that the blood volume, first of all, the blood volume increases up to 50% in singleton pregnancy, which compensate. Why it increases? Because there is blood loss which happens during the delivery. So to maintain that or to compensate that, the progressive increase in blood volume is there. And then out of which these placental vasculature, it receives almost out of it almost receive 30% of the cardiac output. So almost 600 ml per minute at term, the placental vasculature receives the blood from, because of the cardiac output or a heart contractility of the heart. And about 1/6, like 16% of the maternal blood volume is located mainly in the uterus at any time. So anytime you can have a 16% of the total maternal blood volume. And now these blood pressure declines during the first trimester to nadir value. Typically, if you'll see that systolic varies from 85 millimeter of mercury to 110 millimeter of mercury systolic, and diastolic varies between 50 to 70 millimeter of mercury in the second trimester. And these blood pressure again returns to normal or pre-pregnancy value in the closer or at the end of the third trimester. Now coming to the again here important is, following these cardiovascular system, these cardiac output first, they increases by 40 to 50% by 10 weeks due to because this is the time where there is sudden increase in the stroke volume and a smaller increase in the heart rate. So heart rate will not increase much, but a stroke volume will increase very much. We will try to discuss later how these stroke volume affects your left ventricular in diastolic pressure, and how at a particular time, if the stroke volume if then what happens happens at a particular time, the stroke volume doesn't increase enough, and but after adding inotropes, the patient can be prevented on going into a cardiac failure or congestive cardiac failure. So this we will read in a Frank Starling law in later part of this discussion. Now coming to there is always a marked reduction in the TPR. Why? So total peripheral resistance is going to get decreased. So what will happen? There is a systemic vasodilatation that will appear, and these systemic vasodilatation will decrease the blood pressure. Which blood pressure will be more decreased? It is diastolic, which is affected more than systolic. And then again, it returns to the pre-pregnancy level by third trimester. And the second, we were very much aware about supine hypotension syndrome because of the aortocaval compression, which what it basically do, it decreases the preload and it increases the afterload. So that has to be kept remembered in your mind, that how these aortocaval compression is very, very dangerous for these pregnant patients, because many of the time the preload is going to get decreased and the afterload is going to increase. Okay. Now coming to the next important part is that if these patients have a significant maternal hypotension because of that systemic vasodilatation, then what happens? These placenta act separately from the vital organs, and then it start experiencing vasoconstriction. Okay, so if because of the significant maternal hypotension, now these placenta will come into action and it will poses a vasoconstriction effect. Why? This leads to hypoperfusion of the placenta. Okay, with resultant. So if these vasoconstriction at the placenta level will be there, so what does it net result will be there? So fetal hypoxia. Net result will be fetal hypoxia as well as acidosis. Now, so now these two will be very, very detrimental. So that has to be corrected very, very quickly. If placental vasoconstriction will be there, or uteroplacental insufficiency or uteroplacental vasoconstriction will be there, so it can directly result in fetal hypoxia and acidosis, which is following a maternal hypotension. So if you are not going to manage these hypotension very, very frequently, your patient is going to your child or your fetus is going to be impaired. Now here what will happen? You will see that the patient will, or the fetus will, have a variable fetal heart rate, or sometimes these patients may present with bradycardia on a monitor, which is a first sign of maternal status decline. So this may be asked one of the question, that what would be the first sign of maternal status decline? So the answer would be decrease in the variability of the fetal heart rate. If this option is not given, then bradycardia could be another answer, but decrease in the fetal variability is the best answer. How it is been done? Because of the maternal hypotension. So this may be one of the question that may be asked. Now the mother can lose up to how much volume? Up to 30% of her volume before her vital signs changes. So you see that how this compensation is going on there. But still, if you're not going to predict, if you're not going to manage these patients, so if mother has already loosened up to 30% of his blood volume before you notice any change in her vital signs. Okay. Now coming to the next part. The next part from cardiovascular is hematological, where we can very easily understand that this pregnancy is hypercoagulable state, and here the plasma volume is always going to get increased, and then in comparison with red cell volume, there may be dilutional reduction in hemoglobin concentration as well. These patients may have neutrophilia, and they may have 10 to 15% reduction in the platelet count. So these patients may have some forms of thrombocytopenia as well. Okay. Now coming to the respiratory part. So what happens in the respiratory? Because we already read that this progesterone is a respiratory stimulant. So what happens? Many of the time, this increases the respiratory rate. Okay, first. So on increase in the respiratory rate, there is also increase in the tidal volume, and simultaneously the oxygen consumption will also increase. So if the tidal volume is increased, if the respiratory rate is increased, so the overall the minute ventilation is also, or minute volume is also going to get increased. But because of the increase abdomen or increase abdominal size, the residual volume as well as functional residual capacity is going to decrease in these patients. And these patients, again, one of the questions that may be frequently asked as a one-liner, that the pregnant women have a normal respiratory alkalosis. They may give you a small ABG findings, and they can ask that what these pregnant patients normally have. So they have respiratory alkalosis, but how these respiratory alkalosis is going to get compensated with metabolic acidosis. So overall, this this is the question, that respiratory alkalosis following a compensatory metabolic acidosis. Many of the time, these pregnant patients normally have. Now, what basically it does, it increases the removal of fetal PCO2 as well as acidic metabolites. And now the diaphragmatic mobilities later on in the pregnancy is also going to get compromised. That's why in later stage, the FRC is further going to get reduced. Now coming to the next part is what happens exactly over the renal part. So renal part, there is increase in the GFR, there is decrease in the urea concentration, decrease in the creatinine concentration as well. There is mild reduction in the sodium level. So mild hyponatremia maybe is there because of the mineralocorticoid effect, and that's why these patients have net gain in fluid balance. So net gain cumulative fluid balance will be more because of the mineralocorticoid effect, and these patients have from the normal value lesser amount of sodium will be there, which is responsible for increase in weight gain. Now coming to the GI part, so GI part, straight away these patients have increased risk for constipation as well as GERD, and they have increase in alkaline phosphatase level, and then transaminitis will be not there, whereas SGPLT and SGOT values will decrease and albumin values will also decrease. So if now here again a question is there, if maternal oxygen partial pressure falls below 47 millimeter of mercury, the umbilical vein concentration begins to decline. So this is the cutoff value where the umbilical vein concentration begins to decline. Okay. So now again the next part is, now this is again a very important question, that what is the vasopressure that has to be added in a pregnant patient for treating these maternal hypotension if it has happened following subarachnoid block. Okay, so many of these patients have a maternal hypotension following subarachnoid block. So what happens? So vasoconstriction will be occurring in all vessels during pregnancy, and it is important to select an agent because you have to select a inotropes or a vasopressor which preserves the uterine blood flow as much as possible. So our goal is to preserve the UBF values as much as possible. So what you are going to do? So I will be going to do where the uterine vessels, these uterine vessels are maximally dilated. Why they are maximally dilated? Because they have only alpha receptors in their, they are having much density of alpha receptors. That's why these uterine vessels are maximally dilated. So what happens? So you have to use the drugs which have more effect or more better effect over preserving this uterine blood flow. That's why they play a role in determining the sensitivity to sympathomimetic agents as well. Now you see there are four choice of drugs, which could be ephedrine, first choice, which could be phenylephrine, second one, and then dopamine, and then vasopressin. Now you just see one by one that how this is different from others. So if you want to use ephedrine in these patients for treating maternal hypotension, so it is going to get preferred. First point, it has got good safety record. Second best point, that is positive for this drug. This has a minimal effect on placental at low doses. Now this is one of the problem, that if you are using a lower dose, so the effect on the placenta is very less. And what you want to do, you want to maintain the uterine blood flow or placental blood flow in a better way. So here one of the drawback. Second, it crosses the placenta. So again another drawback of using ephedrine, that it crosses the placenta, and they have reported that they can cause fetal tachycardia and acidosis. So if the patient is, if you have not treated that maternal hypotension quickly and you have delayed a time and then you have added ephedrine, so what has happened? Because of that hypotension, the mother have already more increase in fetal hypoxia as well as acidosis. And if you'll further add ephedrine to these groups of patients, so because of the fetal tachycardia, the fetal tachycardia, the fetal acidosis will further increase. That's why it will be compromising the fetus as well. Now again, important aspect is that if you are using ephedrine, bolus is always better for short-lived hypertension. So if a very short span hypertension is there, you can use bolus ephedrine for treating those hypertension. Now you come to the if phenylephrine point. So it causes more uteroplacental vasoconstriction. First, negative point. Now, second, not more fetal acidosis as compared to ephedrine. That's why adverse neonatal outcome is not there as much that what ephedrine can cause. First point. So it is one. It is the added advantage of using phenylephrine that it doesn't have that effect on fetal acidosis as well as tachycardia. Now, again, important point is phenylephrine can be used as an infusion agent if you need, if you think that the duration, longer duration is required for treating those maternal hypertension. Now, this is again an important aspect that has to bear it. That's why many of the questions, the choice would be always phenylephrine, but you must read the question very carefully. But that what they are asking. If they are asking at the at uteroplacental vasoconstriction, so uteroplacental vasoconstriction occurs very less at lower dose of ephedrine, but at optimal dose of phenylephrine, the more uteroplacental vasoconstriction will be there, but fetal acidosis is not as much as ephedrine. Now coming to the dopamine, so it has been studied in few of the patients who are pregnant with sepsis. So overall effect, uterine blood flow, they have not elicited. And dobutamine here, they are talking that dobutamine may be a better choice inotropes because it consistently increase the pulse rate, but it doesn't affect the map. So it doesn't affect the map if you talk about the dobutamine or dopamine. But here specifically, there is no such study which has seen that overall effect on the uterine blood flow. But what they have found, if you are using dobutamine in place of that, so map is not going to get disturbed, but pulse rate is going to increase on dopamine. So overall, they have not used these drugs for treating maternal hypertension. Now coming to the vasopressin, if you want to use intravenous vasopressin or intramuscular vasopressin, so both can cause uterine contractions, and they again it is not required in treating maternal hypertension. So the first choice would be if phenylephrine, and second choice would be ephedrine. But you have to look for these questions very carefully. Now coming to the noradrenaline and epinephrine, so they are a combined statement for these patients, for these drugs, like they can cause considerable vasoconstriction of the maternal as well as placental vasculature in hypoxic women, and short term can be reserved for anaphylaxis, as well as it doesn't affect the fetal blood flow. So if you want to use adrenaline only in cases of anaphylaxis, short-term use of for anaphylaxis, but it does not decrease the fetal blood flow. Okay, so this is all about vasopressors choice in pregnancy and what could be the probable reason of selecting those vasopressors ephedrine over phenylephrine. Now coming to the obstetric hemorrhages, we will now switching towards the obstetric hemorrhages. Like most obstetric hemorrhages occurs after the fetus is delivered. We have already read that postpartum hemorrhage is one of the most common frequent cause of ICU admissions, and these PPH complicates up to 5% of the delivery. And then drug therapy with oxytocin immediately after delivery is one of the standard of care. With additional oxytocin is given if the bleeding is continuing profusely. Now, another choice is you have a choice of using carboprost, methyl ergovin, as well as misoprostol, but they are always second and third line therapies. So second and third line therapies are carbo, ergonovin, as well as misoprostol. Now coming to the few points about methyl ergonovin. So it is a ergot. First, we know it metabolizes via cytochrome P453-4A, and it primarily acts on a smooth uterine muscle. So three important point is there. Ergot derivative we all can understand, but this metabolization is very important. That cytochrome 453A4 is one of the important modes of mechanism, and then it primarily acts on uterine smooth muscles. Now it can cause severe hypertension. So because of that severe hypertension, what it can also cause, it can cause myocardial ischemia if you are going to give this IV. Okay, so IV can accentuates or increases myocardial ischemia. So standard of care will continue with oral therapy at least 1 to 2 days after the initial intramuscular doses. Now coming to the first point, PPH. So before going to PPH, we have to understand that what are the PPH, different definitions of PPH. Now first, it is a obstetric emergency. It can follow following a vaginal or cesarean delivery, and it is commonest cause of ICU admission, which we have already discussed. Now, definition, if any genital tract bleeding after delivery if 500 more than 500 ml after vaginal birth or more than 1 liter after cesarean delivery. So these are two cutoffs. Following vaginal birth 500, following cesarean delivery 1 liter. And estimated blood loss is very, very subjective. That's why the more most likely it is underestimated definition. Now coming to the another definition where excessive bleeding that makes patients symptomatic or may result in showing some signs and signs of the hypovolemia. So what happens if the patient have 500 to 1000 ml of blood loss, like 10 to 15%? So patient may have normal blood pressure values, and these patients have palpitation, lightheadedness, and tachycardia. But what happens if more than 1.5 to 2 liters, means 25 to 35% of the blood volume or blood loss is there? So your blood pressure falls to 70 to 80 mmHg, and then patient will have confusion, oliguria. But later on, what will happen? Anuria will develop only after 2 to 3 liters of blood loss, and these patients have later on will have a lethargy as well as collapse. Again, there is two definition: primary PPH, which happens within 24 hours after delivery. So it is also known as early PPH. Secondary PPH, which happens 24, minimum 24 hours, maximum 12 weeks, means 84 days, means 3 months after delivery. So the secondary PPH or late PPH. Okay. Now coming to the causes, 4Ts, we all know 4Ts, 4T causes like tone, trauma, tissue, as well as thrombin. So any like trauma to the cervix, vagina, perineum as well, and then uterine atony like tone, and then underlying coagulopathy. Now coming to the initial management of PPH. So this is what we used to follow as per John Hopkins Manual of Gynecology and Obstetrics, that IV fluid replacement, 3 ml of crystalloid per ml of estimated blood loss, then PRBC, one after 1 to 2 liters of blood loss, supplemental oxygen, and FFP, means you have to give 1 unit for each 4 to 6. So if you are transfusing 6 units of PRBC, so you have to give 1 unit. So based on that, you can select the number of FFP. And platelet, if it is falling below 50,000, then only you can transfuse that transfuse the platelet. Now, if several of these treatment fails, then you have to target uterine tamponade strategies. And then after that, after tamponade, then surgical interventions. So surgical tamponade strategies would be either arterial ligation, embolization, uterine compression, suture, or last resort is hysterectomy. Blood product should be infused. Recombinant factor 7A has a potential role. Often it often used before you want to do a surgical modalities, but after the failure of other drugs management, but only don't start earlier recombinant activated factor 7A. Now coming to the specific causes of PPH, if you'll see that one of the causes, if the patient will have a uterine atony for which the PPH is there, then bimanual massage of the uterus and as well as OMP. So OMP can be given like oxytocin, methylergonovin, as well as prostaglandin. If some lacerations, so surgical packing. If retained product of conception is there, so you have to do dilatation and curettage, ultrasound guidance. If the patient have a coagulopathy as one of the cause for PPS, so FFP, CPP, as well as platelet transfusion could be done, but only if the platelet count falling below 50,000. Now coming to the facts about PGF2 alpha as well as PGE1 analog. So what does that exactly happens that if the patient is having on carboprost, so these carboprost like 15 methyl prostaglandin F2 alpha, PGF2 alpha, and misoprostol is PGE1. So these are most commonly used in hypertensive movement for treatment of postpartum hemorrhage. So these carboprost can cause what it can cause: significant contraction of the smooth muscle. But only the problem is these patients may feel some diarrhea on using carboprost in 60% of the patient. That's why the patient may require loperamide therapy. And misoprostol is this carboprost is more expensive over misoprostol, but it has been studied for rectal, oral, and sublingual administration as well. Now, vaginal route is not often recommended because patient is bleeding profusely. It may dilute or eliminate the effect of that dose. Typically, 800 microgram or 1000 microgram of drug dose may be used if you are using vaginal route, but already vaginal route is not very preferred. And because of the more available, misoprostol is often used as third line agent. Okay. So there is difference between your PGF2 alpha and PGN. Now coming to the uterine artery embolization, where if the patient is patient is stable enough to transfer, then only you can plan for UAE or uterine artery embolization, which is a very fertility saving procedures, where you can see that through transfemoral route, angiographic catheter is been inserted into the femoral artery, which ultimately going to embolize the uterine artery. And here it will be compromising the supply to that, so the blood supply to this fibroid is going to get cut off, and then the bleeding may be secured in these patients. So transfemoral route, angiographic catheter, uterine artery embolization. Now coming to the surgical therapy, so exploratory laparotomy, so B-link suture and bilateral uterine artery ligation using O'Leary technique, as well as ligation where you want to ligate internal iliac like hypogastric artery. So anterior division of the internal iliac artery can be ligated, and then hysterectomy. Now, this is one of the examples of B-Lynch suture, where you can see that how these B-Lynch suture is going to get applied. So this suture is applied over passing the posterior surface of the, so it is passing over the posterior surface of the uterine surface. Here the round ligament is there. Here is the fallopian tube, and here the suture is passing over the posterior uterine surface, and this is the posterior bite suture. So this is how these B-Lynch technique is applied, and they used to create a, from this the gap is around 4 centimeter, and they should be exactly the entry points for both these is exactly the same point. For posterior bite suture, the entry point would be almost same, and the gap should be 4 centimeters. So these are not very frequently asked, but at least you can understand. Maybe they can give a figure and they can ask that what is this technique known as for postpartum hemorrhage. Maybe they can ask, so you can mark that is a B-Lynch technique. So at least you can see these diagrams. Now coming to the recommended, few points about Novo 7. So Novo 7 approved indication is if the patient is having, you want to treat the bleeding episodes. If the patient is having a hemophilia A or B, or the patient exhibiting some inhibitor to factor 8 or 9 or congenital factor 7 deficiencies, or the patient is having acquired hemophilia. So all these patients required factor 7A administration. So maybe few of the times off-label use can be used for hemostasis of obstetric or gynecological hemorrhage. So how can you give the dose? 60 to 90 microgram per kg body weight, and it can be repeated within 30 minutes if there is no clinical improvements. Now, I will just like to request our candidates to answer this question. Okay, so good. I think you have a fair number of students. So I'm just reading the question. So here you have to mark the true and false statement. Don't try to read in. Try to read the question very carefully, and then you try to mark true and false in the chat box. So this is a woman trial related to question related to woman trial, that is World Maternal Antifibrinolytic Trial. So here the tranexamic acid for the treatment of PPH. So you have to mark the true and false statement. So true, first statement is true. If then you mark TTFF like that. So first option A, woman trial has provided a reliable evidence that tranexamic acid reduces the mortality and hysterectomy in women with clinically diagnosed postpartum hemorrhage. First option. Second, they have written that loading dose of tranexamic acid varies from 2.5 kg milligram per kg to 100 milligram per kg, and then you can start a maintenance dose 0.25 to 4 milligram per kg body weight per hour over a period of 1 to 12 hours in women trial. Third option, these tranexamic acid passes into the breast milk very low concentration, and approximately 1 is to 100th of the concentration in the maternal blood. These tranexamic acid will be compared with matching placebo like DNS 0.9% sodium chloride and dextrose 5%. Women trial is randomized, double-blind, placebo-controlled trial among 13,000 women with a clinical diagnosis of postpartum hemorrhage. So, any of you? Okay, very good. I think some of you have started. Okay, so so one student have marked that he feels that first option is true. Okay, good. So please, you all attempt these questions, so that if you'll attempt here, you will remember it for longer duration of time. I'm not sure whether these women trial is going to get asked in your exam, but at least any of the option is important. They may come in the exam as one of the fact-based option or a statement. Okay. Okay. So many of you have marked. So first option true, then false, then true. Okay. So many of you feel that the first option is true, that these as reliable evidence that tranexamic acid reduces mortality and hysterectomy. Okay. So first option is very much true. The second option is false. Loading dose doesn't ranges from 2.5 to 100. And third statement is also true. Tranexamic acid passes into breast milk. And last two options are not true. So last two options are false. Now you see why. So if you'll see, sorry, if you'll see that these tranexamic acid, if you'll see the conclusion, the main thing is that the main analysis was on intention to treat basis, where they have allocated the treatment receive or not. So they found that primary outcome will be based on the time of delivery and administration or not prophylactic uterotronics. And they found that these patients have clinical decision that to consider entry trial what observed on the estimated blood loss alone. So this is one of the trial that you all guys can go and read for your further knowledge. But here, if you'll see that the treatment will entail a dose of tranexamic acid 1 gram IV, and then placebo 0.9 gram will be given as soon as possible. And the second dose may be given 30 minutes after it continue, or you can stop it 24 hours after the test dose. Okay. So this is one of the question. Now coming to the pregnancy related hypertension. So this is second most common cause, chronic hypertension. What is chronic hypertension? If any pregnant patient before pregnancy, if hypertension is means before 20 weeks of gestation, if the patient has an elevated blood pressure that is first diagnosed, and if it is persisting even after 42 weeks, 42 days postpartum, then it is chronic hypertension. What is preeclampsia? If the patient will have BP as well as proteinuria after 20 weeks of gestation in a previously normotensive patient. And what is mild? A mild preeclampsia, if BP is 140/90, proteinuria is greater than 300 milligram in 24 hours urine collection. And these patients have at least two occasions, at least 6 hours, but not more than 7 days apart. So the values of that blood pressures will be at least measured at least 6 hours apart, but not more than 7 days apart. But now this definition is very, very important, that what is preeclampsia. So if patient is on bed rest, first BP is 160 systolic and diastolic is 110, and the proteinuria is more than 5,000 milligram in 24 hours collection or 3 plus, and then it is accompanied by any one of the following, like any of the one of the following is oliguria, cerebral or visual disturbances, edema, pulmonary edema, or any evidence of MAHA or right upper quadrant pain. Okay. Now coming to the HELP syndrome, which you all know that these HELP syndrome is thrombocytopenia, which has a common value less than 1 lakh, and then this followed by hemolysis, like more LDH, more MAHA, more increased bilirubin, and these AST and ALT always twice upper limit normal. So microangiopathic hemolytic anemia will be more in HELP syndrome. And eclampsia, if these preeclampsia accompanied by if there is seizures or unexplained coma, then it is eclampsia, not preeclampsia. And it may develop even in the absence of hypertension or proteinuria. So this is again very important, that even your eclampsia happens without hypertension or without proteinuria. And here the patient can develop HELP syndrome, which may lead to increased risk of pulmonary edema and severe renal dysfunction as well. Okay, so you must remember Mississippi classification as well. So Mississippi classification is for HELP syndrome, where class 1 detailed about the more severity of HELP syndrome, where the platelet count is falling below 50,000 and AST and LT values is more than 70 unit per liter, and LDH is more than 6. So LDH and these AST value is almost same in the classifications, in all classification, except in class 3, where LT value cutoff is 40,000, but platelet is varying. Platelet is less than 50, less than 50, more than 50 to less than 1 lakh, and more than 1 lakh to less than 1.5 lakhs. So this is how the Mississippi classification has been there. So they can ask that class 1 is more severe and class 3 is less severe. Okay, now HELP syndrome. what you are going to do. So HELP syndrome patient always associated the mortality of 3.5 to 24%, and these mortality associated with because of the renal failure, DIC, hepatic damage, placental abruption, cerebral edema, and these HELP present in antepartum. Even these patients, not only in postpartum period but in antepartum period also, the HELP syndrome occur, and especially in 69% of the patient and 31% of the patient following postpartum. But overall complication or overall mortality is around 3.5 to 24, and most postpartum cases occur 48 hours following delivery. Now, if these patients, so what you will do? So HELP syndrome, if there is a, we want to ensure mother safety. So 34 weeks gestation, what you will do? Delivery is the optimal treatment. Cesarean section is not indicated in every case. Even you can, if the patient is having a favorable cervical condition, so you can initiate the labor using oxytocin, as well as you try to deliver these babies per vaginally, and then close monitoring of the maternal fetal conditions. So if some resolution, for resolution in the first 48 hours after delivery, without, many of the patients have a resolution within first 48 hours after delivery, and even without interventions. Now, if it happens, this was the one situation, if it happens after 34 weeks, help. But what you will do if it happens before 34 weeks? So before 34 weeks, don't do anything, but you almost always start antenatal steroid therapy. How much? Dexamethasone can be used, 10 milligram IV, 12 hours for 4 doses. Why? For fetal lung maturity. And then you can aggressively control the blood pressure by using antihypertensive agents. You can start seizure prophylaxis, bed rest, and 24 hours urine, as well as fetal surveillance, as well as you can perform non-stress tests as well. So postpartum help occur primarily in the first 2 days, but it as can describe as not as 48 hours, but it can may present up to delayed, like 7 days after childbirth. And platelet transfusion if the platelet count going below 20,000, or if you see some oozing continues after delivery. Now, again, this is another question where you have to mark true and false statement about the patient with severe eclampsia, preeclampsia, and suspected HELP syndrome for receiving parenteral magnesium sulfate therapy as prophylaxis for convulsions. Now, here what you will do. So here the magnesium sulfate regimen include loading dose of 6 gram over 20 minutes. You can use continuous infusion of 2 gram per hour, starting during the period of observation and continuing until 48 hours postpartum. And then if recurrent seizure is there, you can you add additional 2 gram of magnesium sulfate, which can be given over 3 to 5 minutes? Or if seizure is not controlled, can you use 3 boluses of magnesium sulfate other than anti-seizures like lorazepam or midazolam? Or as per ECOG task force, antihypertensive therapy for preeclampsia, severe preeclampsia, and HELP syndrome if blood pressure is more than 160 by 110. Okay. So just I will give 10 seconds to mark all those options. So please attempt very fastly because we have to cover too many of questions. So how many of you feels that first option is right? Second option is wrong. Third option is also wrong. Fourth is wrong. Fifth option is right. Any of you? Okay, no issue. But you try to attempt, I think, yes, one, okay, Anita and Muzammil both have attempted. Okay, now you see the answer that the first option, yes, magnesium sulfate regimen, the loading dose is 6 gram over 20 minutes. Second option is not right. You can't start continuous infusion of 2 gram per hour. And because it is not 48 hours postpartum duration, this is not correct. Third option is also right. If you feels that recurrent seizures there, you can give additional 2 gram doses of magnesium sulfate. And then fourth option is not right. Even if seizure are not controlled after 3 boluses of magnesium sulfate, anti-seizures like diazepam can be given. As per ECOG task force, you have to treat if the blood pressure is rising more than 160 by 110. Now you see that explanation here. It has been taken from these two New England Journal of Medicine, Obstetric Gynecology. So here the option is if the patient is having a severe preeclampsia with suspected HELP syndrome, should receive the parenteral magnesium. So the dose is 6 gram, 20 minutes, followed by continuous infusion of 2 gram. But it is not 48 hours postpartum, it is 24 hours postpartum. If you feels that recurrent seizure is there, then additional magnesium can can be given. And if seizure are not controlled after two bolus doses magnesium sulfate, then diazepam can be tried. ACOG can suggest that ACOG task force recommend that antihypertensive with severe eclampsia and HELP syndrome if the blood pressure is 160 by 110. So you have to read these parts also. So these are one of the questions related to parenteral magnesium therapy. Now coming to the next question. So which of the following is true and false statement for platelet transfusion and HELP syndrome? So now I made this question already. We have discussed previously. Maybe one of the two options are from other theory book, but one or two you can definitely going to get marked. That platelet transfusion is suggested for patient with class 1 HELP before cesarean. Platelet transfusion suggested for patient with less than 25,000 platelet before vaginal delivery. Active bleeding patients with thrombocytopenia and those patient with platelet count less than 20,000 can receive a platelet transfusion to receive the excessive bleeding during delivery. You can add platelet transfusion to corticosteroid to increase the platelet count, and it improves the maternal outcome in HELP syndrome. And if you are doing a repeated transfusion, it may be required due to the short half-life. I mean, they say that repeated platelet transfusion required because they have a very short half-life. So how many of you have marked this question fast? So this is how type A and type K question is going to ask in your exam. Okay, Ravindra has attempted that. He feels that for the first option is true, the second option is false, that and the rest all other options are true. Okay, just see. First option is true. Yes, platelet transfusion is suggested for class 1 because it is a severe class, less than 50,000 platelet count. So you have to give, if you are planning for cesarean section, so you have to transfuse the platelet. And the second option, platelet transfusion, is suggested for patient before 20 before vaginal delivery. So it is not a correct option. It is not correct answer. And third option is true. If the patient is actively bleeding with having a thrombocytopenia with platelet count less than 20, definitely you have to transfuse the platelet prior to delivery. And fourth option, no. Addition of corticosteroid to platelet transfusion, it is not going to improve the platelet count as well as maternal outcome in HELP syndrome. And last option, if you want to do a repeated platelet transfusion, it is not required because of the short half-life of the patient. Now you see that options. First, platelet transfusion is suggested for patient with class 1 HELP syndrome. Yes, less than 25. Moreover, this patient have, moreover, actively bleeding patient with thrombocytopenia and all those patients with platelet should receive a platelet transfusion prior to delivery. However, repeated platelet transfusion not required due to short half-life. And then here, even the Gracia reports have reported that the addition of platelet transfusion to corticosteroid therapy to increase the platelet count does not improve the maternal outcome in HELP syndrome, and that's why these all options are as per this. Now coming to the seizure prophylaxis. So seizure prophylaxis, when you will going for a seizure prophylaxis during labor and for 24 hours postpartum for all patients. Okay, so 6 gram loading, 10 to 20, 15 to 20 minutes, you have already read. Maintenance dose 2 gram per hour. It may be titrated up to higher doses, but your target is to maintain a therapeutic magnesium level of 4 to 6 milliequivalent per liter. Phenytoin can be used as for recurrent seizure prophylaxis. Magnesium sulfate has shown to superior to phenytoin in preventing seizure in recent trial. So if you have option of using magnesium sulfate, always use magnesium because it is not better over phenytoin. And however, individualization of phenytoin doses is recommended, but it is not followed in many of the trials. Okay. Now coming to the end treatment. Also, the treatment of choice for managing this postpartum diastolic blood pressure, if it is more than 105, IV hydralazine, IV labetalol. Okay. If now this is again a very important question that how these drugs like your ACE inhibitors, like your ARBs, like your beta blockers, like your calcium channel blockers, so how it is going to get affected. Now here, what is there? There is a milk is to plasma ratio and then protein binding. So what they suggest that if you are using candy, irbi or losartan or valsartan for treating these patients for hypertension, so what they found, they have a very unknown, their MP ratio, like milk to plasma ratio, is not been calculated, and they found that low molecular weight of these agents suggests excretion into breast milk. So they get excreted in the breast milk, but no human reports are still available. So you cannot use, its recommendation is not there. Okay. And there is sufficient data to use captopril and enalapril to classify these patients as compatible, means they are compatible for treating hypertension, and they can pass into breast milk, but no human reports are available to make recommendation about their use. So this is how, if you are talking about labetalol, this is compatible, but still no human reports with carvedilol, and you can watch for alpha as well as blockade, beta blockade effect. So there is, I want to explain here that there is a term called milk to plasma ratio. If you see that milk to plasma ratio, many of these drugs based on the milk to plasma ratio. So the more the drugs which are having these higher milk to plasma ratio, means higher milk to plasma ratio, they can cross into breast milk very easily. Okay. So this is what I mean to say, that the drugs like your beta blockers, they have some certain milk to plasma ratio, whereas the ACE inhibitors, they also have certain milk to plasma ratio, but undetermined milk to plasma ratio for ARBs. That's why these drugs are not being used for treating hypertension. Okay. And there are some few loop diuretics also which decreases the milk production. That's why I have added this slide for your sensitization, so that you all guys can go and read about milk to plasma ratio of these drugs based on the treatment of hypertension. Okay, now coming to the fluid management, I'll not go in details, but yes, renal replacement therapy, one of the pressure, one of the advantage of on using RRT in these groups of patients is very, very effective. And second, you want to, because these patients are hypovolemic because of the fluid loss, that's why you want to preserve the oncotic pressure as well as improve, because it's going to improve the capillary permeability as well, because these have increased capillary permeability, so capillary leakage will be there, and you can restrict the IV fluid. Now, one of the very one-liner question, that is only one statement is right. The which of the following maternal complication here? Hepatic capsular rupture. Hepatic capsular rupture is seen in HELP, TTP, severe preeclampsia, acute fatty liver pregnancy, or antiphospholipid antibody syndrome. So only one answer is right. Any one of you can mark what you feel that is true. Okay, good. Many of you are going with AFLP. Okay, so again, it's been taken from one of the straight question, that why these hepatic capsular rupture appears. Now you see very carefully. I think okay, hepatic capsular rupture will read later on. I have added it somewhere else, but here you can read that these hepatic capsular rupture happens or occurs in severe preeclampsia. Now, next question. Which of the following, what I feel that everyone should mark this option true. Okay. So all of the following are severe features of preeclampsia, except only one answer is right. So we have just read preeclampsia. So what I feel that you all should mark it right. Which of the following options? All of the following options are true, except one option which is not true. Okay. C, D, okay, A, good. Okay, it's good that you all guys are attempting, at least attempt. Okay. Okay. So this is the option, like progressive renal insufficiency with serum creatinine more than 1 milligram per day. This is not true statement. Now you see why. SBP of 160 or higher, or DB 110 or higher on 2 occasions at least 4 hours apart while the patient is on bed rest. Okay. Thrombocytopenia, definitely impaired liver functions. Yes. How you can see by 2 times the normal concentration, and then progressive renal insufficiency, like more than 1.1 milligram per dl or doubling the serum concentration. There should be pulmonary edema. There is new onset of visual disturbances. So this is how just I played with this option, like I kept 1 milligram per dl and it should be 1.5, 1.1. So it is very close option. So I think you have to read very carefully. Rest all options are right. Okay. So all these statements are right. Now coming to the next point, amniotic fluid embolism. So here it's one of the rare so it is one of the rare complication, but it has a very high mortality. You can see that PPH uh, or HELP syndrome has a mortality of 25 up to 23.5 to 25%, but here it can go up to 35%. And you can see in 1 in 8,000 and 1 in 80,000 pregnancies ending in live birth. And the clinical features, what is the classical clinical features? So these patients have amniotic fluid embolism always present acutely during the labor or after delivery or immediately postpartum. So classical is hypoxia, hypotension and with shock, altered mental status, and DIC. Pulmonary hypertension maybe few of the patients may have pulmonary hypertension, but it is going to get subside and it is replaced by acute left ventricular failure and then seizure and then respiratory distress, fetal respiratory distress. So how are you going to diagnose? So it is basically a diagnosis of exclusion. So the patient, if the patient is acutely very ill, profound shock and cardiovascular collapse just after delivery, so you can make a first differential diagnosis of acute your amniotic fluid embolism. So what would be the DD? Pulmonary embolism, hemorrhage, as well as MI. Now the next point is, so here so what happens here that these patients, like what happens here that these patients exposure to amniotic fluid or fetal antigens. So it has four different aspects or four different outcomes. Like they can release immunological mediators, they can have a mechanical obstruction, they can have a complement system activation, and they can have a coagulation system activation. So coagulation system activation, till now we all know that coagulation system activation leading to consumption coagulopathy and then cardiovascular collapse. But these cardiovascular collapse can happens because of these release of mediators like surfactant leukotrienes as well as thromboxane A2 and platelet factor 3 phospholipase, or some like your tissue factor 3, all can release biochemical mediators, and then there could be a mechanical obstruction. Large volume of amniotic fluid can obstruct the leading to cardiopulmonary effects, and that's why the acute pulmonary hypertension or right ventricular failure can happen. Even it can lead, if right ventricular failure is not treated properly, it can lead to left ventricular failure, and here only the patient will have a ARDS or acute kidney injuries symptoms. Okay, so this is how amniotic fluid or antigens is going to affect. This is basically a pathophysiology for development of AFE. So now how are you going to get managed? So early diagnosis, first priority is to deliver the fetus. Okay. Then aggressive supportive management, IV access, PRBC, and prostaglandin synthesis inhibitors and high dose corticosteroids have been suggested to treat the condition. Why? Because there is large release of inflammatory mediators in the forms of phospholipase A2, leukotrienes, and then your platelet factors 3. Then there are lots of you we have already discussed initially. Now, this is again question. All of the following statement is correct regarding amniotic fluid embolism, except so you have to pick the wrong statement. Hypertension is the most common presenting signs and symptom, almost in 100% of the patient. Chief radiographic abnormalities in AFE is diffuse, bilateral, heterogeneous, and homogeneous areas of increased opacity. You may find increased serum tryptase, decreased urinary histamine concentration, and significantly high C3, C4 complement concentration. Base excess increase on ABG, and tonic-clonic seizures seen in 10 to 15% of the acute fatty embolism patients. Okay. Anyone? Which option you feel is not right? Okay, so again, it's a very important topic. you see that option answer is C. So this is the only option which is not correct. So here serum tryptase, urinary histamine concentration, and high C3C4 level doesn't appear. Okay. Now again, I have just added another question on acute fatty amniotic fluid embolism. Now you hear the type K question is there, so you have to mark true and false statement. So what do you mean by typical? So in classic, it is phase one where respiratory and circulatory disorder occur. In phase two, coagulation disturbance and maternal hemostasis will occur. Phase three will have a ARF and ARDS, and atypical AFE has cardiopulmonary collapse. It doesn't occur, but first symptoms life-threatening hemorrhage. As hypoxia and hypoxemia is progress, so circumoral peripheral cyanosis and change the mucous membrane will manifest. Amniotic fluid embolism may occur up to 5 to 2 hours post-delivery, and AFE occur in healthy women during labor, cesarean, and during abortion and second trimester of pregnancy. Okay. Okay. One. Good. Chalo, at least you guys are attempting. It's good to see. So now you see that option answer. Almost all statement are true. Why I have put this question? Only for your understanding, so that you all guys can understand what is what is amniotic fluid embolism and what are the options that fits into it. So this is the D option, which is not correct. Okay. So this is the correct, not correct option. Rest typical AFP, atypical AFE, hypoxia and hypoxemia. How will you going to detect in as a peripheral cyanosis? And AFP may occur in healthy women with labor during cesarean. Now see how. So here, this is a bin classification. I think it's a published in JOSCP in 2020, in 2016, where they have very clinical symptoms. Here, from here, you can see that typical is classic with three phase. Phase one, respiratory and circulatory. Phase two, coagulation disturbances, and phase three is ARDS and ARD, like acute renal disease. Atypical will have a embolism, and atypical is observed during cesarean section. And then here also there is clinical presentation and all. And I think it's a good article to read. You all guys can read this. So here just I have added this typical and atypical AFE. Okay. So that's why it is important, this slide. Now coming to the peripartum cardiomyopathy. So it happens mostly in the last month of pregnancy and at the end of the fifth month postpartum. So how are you going to diagnose these patients? So if the patient doesn't have any history of cardiac dysfunction, or you are not able to identify the cause of the heart failure, so you can think of PPCM. You can, if the patient will have a new left ventricular systolic dysfunction. So if left ventricular systolic dysfunction is there, if the ejection fraction is less than 45%, if the M mode fractional shortening is less than 30%, with more than 2.7 centimeter meter square in diastolic. So EDD is, so if in diastolic dimension is more than 2.7, so if there is elongation in that dimension, and then M mode fractional shortening is there, so you can think of making peripartum cardiomyopathy. Okay. So now coming to the diagnostic criteria, the same that what I have discussed. Development of cardiac failure. If the patient has in developing cardiac failure in the last month of pregnancy or within 5 months of postpartum, you are not able to identify her cause of cardiac failure, and you are not able to recognize any heart disease before the last month of pregnancy. And additionally, ejection fraction on echo less than 45%, fractional shortening less than 30%, and the in-diastolic dimension has increased more than 2.7 centimeter square. So you can think of that this patient is developing the peripartum cardiomyopathy. So always try to consult cardio, obstetrician, and perinatalologist. Now, coming to the risk factor, advanced age, multiparity, obesity, and gestational or chronic hypertension. So PPCM is similar to idiopathic IDCM. So it is also known as IDCM, that is idiopathic dilated cardiomyopathy. Okay. Now here the viral myocarditis can cause autoimmune disease, maladaptation to hemodynamic stress, and if onset of symptoms typically after 32 weeks of pregnancy. Now, here the initial symptoms in the last month of pregnancy, how these symptoms will present. Normal present like fatigue, dyspnea, and edema, and these most patients present with significant heart failure like paroxysmal nocturnal dyspnea, like new heart murmurs, like chest pain, like jugular venous distension, then pulmonary crackles, and these patients may have a very high risk of thromboembolism. So always you think for thrombotic cerebral infarction in these patients. May they can give you option that the patient presented with delay in the later half of the pregnancy, like 32 weeks of pregnancy, and the patient will have a delayed decrease consciousness, and the patient was having a on CT scan, a cerebral infarction was there. So, and the patient was having a dyspnea with fatigueness. All of these can be given with a echo finding showing the ejection fraction of less than 45%. So you can think of that this patient has developed a thrombotic cerebral infarction, and if the cause would be IDCM or PPCM. So here the patient will have a significant morbidity and mortality approaches to 20% if not going to treat on time, and then prognosis is dependent mostly on the normalize. So you want to target, you have to normalize the left ventricle function. Okay. Now coming to the after that, this is again an important question is that how we are going to how we are going to predict the poor prognosis. So if the EF is further less, only 25% poor prognosis. If the left industrial dimension is more than 5.5 centimeter, if you are seeing the QRS is very short, less than 120 millisecond, if the patient is having a subsequent pregnancy, so all of these are having a poor predictors for or poor prognosis for PPCM. And but one important finding is that they have good prognosis, and 50% of the women with PPCM will recover to their baseline cardiac function, means their left ventricular dysfunction will return to normal, and only more and they have more than 50% improvement. How? When they are when within 6 months after presentation. So you have to wait for another 6 months, but definitely all these important predictors of poor prognosis can be kept in your mind. Okay. So now important is how you're going to treat that. So you have to treat as per your CHF guidelines, like as per your congestive heart failure. It's parallel to CHF. A's are contraindicated. Hydrogen and nitrate should be used. DOPA, dobutamine, NTG, milrinone can be required for treatment of acute management. And if the patient is in last month of pregnancy, fetus should not experience the teratogenic effect of NTG. Blood flow to the uterus and fetus will be improved by NTG, but you have to take care that the patient should not be in the last month of pregnancy. And even the oral regimen of hydrogen and isosorbide dinitrate are appropriate. Even pentoxifylline and prolactin inhibitors are successfully tried for the treatment of PPCM. And dose is 1 gram per kg body weight of IVIG for only 48 hours, because it improves the left ventricular ejection fraction. IVIG should be reserved if you're feeling some infectious etiology like your viral or something, then you can think of, or you can measure the TNF alpha in these groups of patients. So it may have increased TNF alpha, which is persistent with left ventricular dysfunctions. Pentoxifylline, that's why the role of pentoxifylline is there, because it directly inhibits the TNF alpha production. And pentoxifylline can be used 400 milligram 3 times for 6 months. And left ventricular diameter have a if it is significantly smaller, so you can. So what the study they have done, they found that if the left ventricular diameter is significantly small, they were seen that the fewer deaths in the pentoxifylline group were there. Okay. Okay, and prolactin concentrations are also elevated in postpartum, and they induces the breast milk productions. That's why prolactin derivatives, because more oxidative stress is there. That's why it increases more prolactin derivatives, which induce endothelial cell apoptosis, and it disrupts the capillary structure as well. That's why bromocriptine and cabergoline have produced a good recovery, because they are prolactin, because they inhibit the production of prolactin, and then simultaneously it improves the capillary structure and retards or inhibits the endothelial cell apoptosis. And these bromocriptine, but the role using bromocriptine is increased risk of severe and myocardial infarctions. So now, important point till now is to remember the board regimen for treatment of peripartum cardiomyopathy. So these board regimen consist of B for bromocriptine, O for oral heart failure drugs like beta blocker and ACE inhibitors after achieving a hemodynamic stability, and then A is for anticoagulant. So you have to start early heparin because these patients have a very high risk of thromboembolic episodes. That what we have already discussed. You can definitely start relaxant like vasodilators, mostly NTG, but you have to think whether the patient is in last trimester of pregnancy or not, because to retard your teratogenic effect. And then definitely for D, you can use furosemide. So this is board regimen. Okay. So now question. All of the following is true about PPCM. So only one statement. Okay. Which of the following you feel that it is true? So all of the following statement are true. You have to pick the false one. Development of heart failure in the last month of pregnancy within 5 months postpartum. Prognosis is dependent on the normalization of the left ventricular functions. The end-diastolic dimension LV is more than 2.6. M mode fraction shortening is less than 30, and board regimen is used for acute PPCM. So I think it's a straight question. So many of you can mark it right just now. Okay, C, good. Good. I think you got it right because I just modified this option. Rest all options are correct. Perfect. Good. So now coming to the next point, next question is now here. The important thing is basically a concept that you have to understand, that why cardiac failure happens in pregnancy. Okay, why, and how these inotropes is going to improve this cardiac failure status. So you see, this is a Starling law. Okay, so in y-axis stroke volume, right? In y-axis stroke volume, and in x-axis, this is showing the left ventricle in diastolic volume. So what happens when you will fill on pregnancy, what happens? There is progressive increase in the stroke volume as long your filling will be increasing the ventricle, right? So a point stroke volume increase on increasing the left ventricle in diastolic volume increase, but a particular time, this x value, after which the stroke volume will not increase, the stroke volume will started to fall. You see that the stroke volume has fallen. Now on reducing this stroke volume, what happens? That if you'll see that here the stroke volume is falling, so in the right side part, the patient will have a heart failure. Okay, why? Because the muscle is less effective here. The muscle will be less effective if you want to add inotropes here. Okay, if you want to add inotropes, because stroke volume is also already feeling, so on even on addition of inotropes, the muscle will be less effective. But on addition of inotropes here on the left side, the contractility is going to improve because of the why? Because of the increase in, because these stroke volume is directly dependent on the left ventricular diastolic volume, but for a particular time. Once your plateau has been achieved, once your feeling will be adequate, and if you want to overfill those patients, the chances of going in cardiac failure will be always high. Why? That's why if you increase the intrathoracic pressure, the venous return will decrease, and indirectly the preload will decrease, and left ventricular diastolic volume will decrease. So this is the basis of Starling law. So you have to understand. So this is very important, that at what time you have to add inotropes. Okay. Now coming to the, so this right showed cardiac failure, and here the left showed improve muscle contractility. So if you add inotropes here, so muscle contractility will improve because the muscle strength will be preserved here. But once the muscle strength will go off, even on adding inotropes, the patient will have a high cardiac failure, or the patient or cardiac failure will not improve as much in compare with on adding at this point of time. Okay. Now coming to the next part. So cardiac failure, if you want to improve the preload, add diuretics. If you want to improve the afterload, as vasodilators, but you must rule out cardiogenic shock. If you want to give intermittent positive pressure ventilation with good PEEP, so always try to put these patients with good sedation. Don't try to create a ventilator dyssynchrony. You want to target increasing your PO2 and SO2 values as well. Okay. Now AFLP. So this is a potentially fatal condition. First, mortality rate 18%. No direct cause of AFLP has been elucidated, and lipid accumulation can occur in the liver, kidney, pancreas, and brain. And there is a strong link that there is abnormalities in the fatty acid oxidation and ammonia produced by hepatic cells. So excessive fat content in the liver, which is that's why profound hypoglycemia in these groups of patients, and they can present as early as 23 weeks. Okay, so flu-like complaints like nausea, vomiting, and then jaundice and fever, diabetes insipidus, polydipsia, and polyuria, but it is a very rare. Fulminant hepatic failure, hepatic incave, decreased level of antithrombin 3, and they can develop hypertension, preeclampsia. You may get fetal acid-based status abnormalities, and but till now, no reports of AFLP resolved prior to delivery has been reported. Okay, so diagnosis: hyperbulimia, transaminitis, coagulopathy, hypoglycemia, and these patients may mimic with like severe preeclampsia, HELP syndrome, renal failure is also very common. So definitive diagnosis is always made by liver biopsy, but it is rarely performed. Now, what you will do on, so it is going to get worsened first 2 to 7 days after delivery. So if but many of these patients have improvement in the hepatic, renal, and hematological profile as well. And liver transplant is if the patient is having a liver rupture with necrosis or permanent hepatic failure or hepatic encephalopathy or worsening coagulopathy, then your liver transplantation is the choice. Activated protein C can be used. Use of plasma exchange can be tried. And if the patient receiving plasmapheresis in progressive AFLP, so these patients means if the patient is having a deteriorating mental status first, if the persistent coagulopathy is there, renal failure is there, pulmonary compromise is there, so you can add plasmapheresis. But how long? Until unless it is resolved within 14 days, or average of 3 plasmapheresis. So 3 cycles of therapeutic plasma exchange can be done for treatment of AFLP. But if these patients have deteriorating mental status, renal failure, progressive renal failure, or pulmonary compromise. Okay. Now, this is one of the questions that I think, okay, we have discussed previously, that what are the differential diagnoses? So I think this is one of the differential diagnosis of AFLP, like severe preeclampsia, HELP syndrome, viral hepatitis, TTP, and anti-phospholipid syndrome. So this is how everything is written. Okay, preeclampsia. Okay, I asked one question that hepatic capsular rupture. So hepatic capsular rupture appears in preeclampsia, but in acute fatty liver of pregnancy, no such. Only hepatic failure will appear, and in hepatic hemorrhage will be there in HELP syndrome, and hepatic coma will be there in viral hepatitis, and then your subcortical means bleeding will be there, TTP. But here placental thrombosis will be there, and here antiphospholipid syndrome, which we already discussed in APLA. So this is one of the points that could be remembered. Now, so IHPC, so ISCP is intrahepatic cholestasis of pregnancy. Again, etiology is unknown, but genetic, hormonal, environment influences is there, and it is diagnosed clinically. It is characterized by pruritus, elevated bile acids, and transaminitis. It is mostly pruritus is intolerable and worse as night. Maternal prognosis is good, and it is basically disease progression is limited to delivery, and it is associated with fetal morbidity and mortality. Maybe many of the times IUCD, but it is very rare, and it is associated with PPH and severe cases with maternal hypoprothrombinemia because of the absorption of vitamin K. Now, potential causes of jaundice in critically ill patients. So these are the list where they can enumerate if they ask a STEM type of question in EDIT 2, when you will appear for EDIT 2, they can ask that what will be the potential cause of jaundice in critically ill patient, and then they can take one of the like drug-induced methyl dopa, and they can make that all those STEM of questions. So acute fatty liver of pregnancy, obstetric cholestasis, viral hepatitis, sepsis, 3 causes like cholestasis, ascending cholangitis, drug-induced methyl dopa, pre-existing liver disease, and PBC. So now again question based on acute fatty liver of pregnancy. So you have to mark true and false statement. First is LCHAT deficiency is responsible for 20% of the cases. Histological appearance of liver is inconsistent with macro and microvascular fatty acid infiltration. Pregnant women with AFLP present in second trimester, usually between 20 to 24 weeks of gestation. And AST and ALT are always elevated in patient with AFLP. So ACOG clinical guidelines recommend prompt delivery of AFLP. So here you have to mark true and false statement. Very good. Dinesh has attempted, I think, he feels that first statement is false. Rest all other statement as true. Anyone who wants to attempt? Okay, good. So here, the first two statement like B and C are false. Rest all statement as true. So it is not true. This statement is false, and this statement is false. Rest other statement are true. So this is LCAT deficiency, 20% of patients, and then aspartate and ALT are always elevated, and ACOG says that delivery is important. Okay. The second Swanson criteria for diagnosis of AFLP all accept. It is again very straight question. Mark it fast, quick. Swanson criteria, all of the following except. So only one option, yes. Victor feels that yes, presence of polyuria. Okay. Anyone other? So it is B. Ammonia is not more than 37. It is, I think, more than 50, something like that. Okay. Ammonia is more than 47. Okay. And histological pressures is microvascular steatosis on liver biopsy. So here the option is a bit twisted. Here 37 I have written, and the option will be more than 47. So here clinical lab features bilirubin, hypoglycemia, WBC, ASTLT, AKI, coagulopathy, ammonia, urate. So ammonia they used to ask. Urate they have not asked till yet. Ascites ecogenic already asked. Microvascular steatosis on liver biopsy has been asked. So they may ask about urate values also. Now coming to the few points over the human swine influenza in obstetric patient, only few slides. So they have done a critical illness population-based cohort study. They found 64 patients on recently postpartum women with with influenza H1N1 admitted to ICU. What they found that they have increased risk of admission to ICU for gestation week more than 20 weeks. They are requiring mechanical ventilation. They are requiring ECMO, and they have mortality also. So this is how they have added that clinical management is oseltamivir for enteral, zanamivir for inhalational route, and peramivir for IV route. Empirical antibiotics can be added, but there is not very proven role for convalescent serum, hyperimmune globulin, or that zinc and high dose N-acetylcysteine as well. But mechanical ventilation and ECMO has a role, and empirical antibiotics has a role, and some neuraminidase inhibitors like oseltamivir, and then they basically has a potential benefits outweigh the theoretical risk to fetus, and they are category C drugs. And human swine influenza vaccination, all healthcare workers, those patients who are pregnant, they have to receive the swine influenza vaccination. And children, if they are 6 months or less than 6 years, they have to give. Elderly person 65 years. So COVID-19 and pregnancy, few points what we have learned through, because it's a CDC guidelines. I have added this point from CDC only. I don't think so that they will ask these questions now, but still for you all benefits, I have added that people who are pregnant or recently pregnant are more likely to get very sick from COVID-19, and COVID-19 increases the risk of delivery at preterm, mostly at less than 37 weeks of pregnancy, and they have an emergence with Delta variant as well, and they are also associated even greater risk of severe outcome with Delta variant. And what they found that in pre-Delta period and Delta period, the risk of ICU admission was 41 times higher in the Delta period. The requirements of invasive ventilation or ECMO was 83 times higher in Delta period, and the risk of death in Delta period was 3.3 times than pre-Delta period. Okay. So these are few facts, and on the further analysis, they compared that pregnant women in cases of pregnant women with cases in non-pregnant women age 15 to 44 years. They reported that compared to non-pregnant women, pregnant women have 5 times more risk of ICU admission, 76% risk of invasive ventilation, and during the Delta period, the risk of death was 1.3 times. So this is pregnancy related to breastfeeding guidelines. So this is in nutshell about the obstetric emergencies. So if you have any question, you can X me at dear Neeraj underscore NSP, or if you have any query, you can note down my email ID for any questions related to obstetric emergencies. So if you have any question, you can ask me here right now. And please try to read all those obstetric emergencies that what we have covered today, and just individual step by, because there are many things that have been added from the ESICM module also, and many of the things has been taken directly from the textbook as well, and many of the things has been taken from the journals, and few facts were taken from the your EDIC notes. Okay, so this is from my side. If you have any question, please do ask, and please be ready to read about obstetrics. Don't try to miss any questions in EDIC 1 if asked related to obstetric emergencies. Anyone have any questions or any doubt?
Any aspirants who have question, you may ask now. So
You
I
can
guess
write.
we don't have
Yeah.
any questions.
Okay. So
Mhm.
thank you so much.